Okay, Pallavi madam.
Vinayak sir, please start.
Yeah.
Please start, sir.
Ram Gopal sir, you can put initial remark, then I will start.
Okay. Friends, good evening. Welcome to another episode of Casebook Live. Before I think Vinayak Patki sir goes live, as you know, that we don't know what would come out of his box. It's always a googly. Nobody knows. Even the experts, they don't know what is the case. So it would be the approach to the case which is more important rather than what is the diagnosis, which is the principle of our this session. Now, I welcome Dr. Sachin Shah and Dr. Tarun Kanade, who would be the experts who would be giving their comment on the case, and Dr. Suraksha and Dr. Minja. They are students from Miraj Medical College, and their mentor, Dr. Bhavesh Shah. I welcome you all. I think already it's 9:04, so I will not come in between Dr. Vinayak Patki's case. Sir, you can start the case.
Okay. Am I audible and screen is visible?
Yes, sir.
Yes,
Screen is
sir,
not
yes, sir.
visible, but you are audible.
Kindly make it full
नहीं
screen.
नहीं screen is visible, casebook live आ रहा है, but make it in a PPT format.
Yes,
Yeah.
yes.
Now it
Yes, yes, sir. It is full screen now.
Yes. So good evening, friends, for yet another episode of Casebook Live. This is the fifth case, and we have eminent, as Ram Gopal sir has already introduced, we have eminent experts today. Dr. Sachin Shah sir, he doesn't require any introduction. He's a pediatric intensivist and head director of Surya Hospital from Pune. He's a secretary, he's treasurer of IIP Intensive Care Chapter. And Dr. Tarun Kanade is a senior pediatric intensivist from Nashik. We have a team of government medical college mirrors, and with their Dr. Bhavesh Shah, he also is a well-known personality for the BLS course. So without wasting much time, just we'll go for the first case. The pattern all of us we are knowing. Just for PG students, once I will go through case, first I will ask your impression about that up to that particular moment. And after your opinion for each point, I will go to the experts. And as the case evolves, we'll start discussing it in a more detailed manner. So please remember for PG, this is not diagnosing or not able to say something and all that. Just as Ram Gopal sir has already said, this is just approach and how we can see the complications or different kind of things in our day-to-day practice. So this is our team. As already, we welcome all of you and all the delegates who have joined for today's session. So this is a 7-year male who has come to us from outside hospital with recurrent abdominal pain. Now started complaining of headache, vomiting, and abdominal pain, which was more than what previous episodes for last 15 days. Received symptomatic treatment in the form of antiemetics, PPIs, and antispasmodic symptoms, but symptoms went on increasing. So he was admitted in the local hospital with moderate dehydration because of vomiting. There he received IV fluid, Imset, Reglan, Brufen, and Monosep. He was investigated outside there, and it shows CBC of 10.2, total count of 5,600, eosinophils 7, and platelets of 1,63,000. Vidal was 1 in 80, urine showed 3 to 4 pus cells, and CRP was positive quantity. They have not mentioned the exact value. They have done UHG abdomen there in view of recurrent abdominal pain, and which was showing partial left pelviureteric junction obstruction and impacted fecalith. So, but child had increased vomiting, intense abdominal pain, and headache. Now he started extreme irritability. So the local people have given, he has received midazolam twice for irritability, and that the child become a bit drowsy, and that's why he was referred to tertiary care hospital. So on examination, he was afebrile, no dehydration. He was drowsy but delirious and arousal. Heart rate was 74 minute. BP was 138 by 84. Respiratory rates were 20 per minute, shallow respiration. And SpO2 on room air was 92%. He had mild pallor, serious no murmur. Respiratory system was not significant. Abdomen was quite distended, tenderness at left inguinal region. Bowel sounds were quite sluggish. Liver was 2 centimeter palpable. On general examination, he has hypotonia, which can be contributed to the his Midas injections, and DTS were +3, plantar extensor, and pupils were equal and constricted. So just going to the PG student first. So what is happening to this child, and what is his physiological status, maybe clinical diagnosis and investigations. So over to the PGs first.
So could you please repeat the last slides? We were not able to see, like network
Okay.
issues were there.
So this child with recurrent abdominal pain and now come to you with he was received because of irritability and pain. He has received Midas injection, and then child was referred here. And this is the basic general examination at ER. Yes, you can start discussing. Yes, speak.
As the child is having complaint of abdominal pain since 15 days and with vomiting, and now the condition is deteriorating. So it can be because of persistent vomiting. Now the child can have some dyselectrolytemia, one of the thing, and
Okay.
then current abdominal pain and left-sided tenderness with some. He had pelvic ureteric junction obstruction also.
Yes.
So it can be some stones or some renal condition leading to recurrent abdominal pain and dyselectrolytemia leading to other features in the child.
Okay.
But the child condition get deteriorated after giving the Midas and everything. So we can even think of some hepatic pathology also in this child, as some enzymatic derangement in the child. So, is there any other past history relevant to it, like before 15 days even had these episodes again, like
Your voice is breaking.
ruled out some inborn error of metabolism leading to abdominal pain, vomiting, and recurrent episodes of these things.
So there is nothing. The child has only had recurrent abdominal pain, and these are the investigations. So how will you proceed now for investigations? I think your internet connection is not stable. You can your voice is cutting. You can stop your video sharing so that
Yes.
your voice will come better.
Yes. That's what I'm trying to say. Ma'am, stop your video and then try to speak.
For us to suspect in so this is the investigations suggesting that the investigations are almost normal. HB is almost common for this child to see. We'd like to further evaluate this child.
This child has been whatever I have shown investigations of previous. We have not investigated at our hospital. So what investigations in this kind of cases you will advise in ER?
Sir, I would like to interrupt, sir.
Yes, please.
Sir, before investigations, I would want to know what is the thinking process? What is the clinical diagnosis at the onset? Like, if we go to the IIP, ALS, BLS approach, what is the child having right now? Is it what physiological state would be classified into?
Yes, that's why I put physiological status there.
Yeah.
So I missed there. I could not able to hear from them because of
actually we also didn't hear. So they can repeat if they can.
Yes. So you can repeat. Say the physiological status of the child. Suraksha. Are you there? Are you there online?
Yes, sir.
Are you there online?
So could you please show the previous slide?
Yes, yes. Just on this, you say, as Dr. Tarun has really pointed out, you tell us about the physiological status of this child.
Yes, sir. Yes, sir. Sir, could you please show the previous slide of
So this is the physiological status is shown on
examination of
this
child?
slide. No? I have given you all appearance for
So as
ABC,
the
everything.
child has recurrent abdominal pain, vomit. With there is this. As a child, per abdomen, there is distended tenderness at the left inguinal region with sluggish bowel sounds. So we would, mostly some GI pathology can be there. So we would like to go for, and there is generalized hypotonia also in the child with the DTRs +3 with plantar extensor. So first, if we would like, there's some CNS component is also there in the disease. And but if we will first like to go to do the this thing, LFT and serum electrolyte of the child.
Okay, Tarun, you can just talk about physiological status and then we'll go.
I think so. One important question I would like to ask on examination, before I go to this thing how was the vomiting? Was it bilious, non-bilious? Was it projectile? How was it? Because if there is an abdominal pathology, I would suspect then there should be a bilious vomiting.
Bilious was not there, but vomiting was quite frequent. What they would able to say.
And despite giving antiemetics, the vomiting is persistent. So if it would have been a GI pathology, then it should be really a severe one.
Okay.
Cause so much of
Tarun,
vomiting.
before that, no, just they have told now 2-3 possibilities. I think
before we go to the differential diagnosis, like my basic question is, when this child is assessed in the ER, is the child stable or unstable? Is the child sick or not very sick? Just tell me that. That's what the students tell me.
Yes.
So child is drowsy, so definitely doesn't look to be stable. He's delirious and arousal. So
no, not Tarun, not from you. Like the students have to. You cannot answer.
सवय झाली उत्तर द्यायची.
Child is drowsy.
So in these numbers, what all is wrong in these numbers? Forget your diagnosis and investigations.
Correct.
A, B, C you talk, na? Dr. Suraksha. You talk about PAT triangle first.
Yeah, exactly. What is the PAT assessment?
I think so. They are having network issues.
Yes. So as the pulse rate is okay, sir. 74. Also.
Network issue. I think shall we proceed because I'm not.
74 per minute.
Vinayak sir, I think you can proceed because
yes, because there is issue. I think I will proceed.
Issue. Yeah.
Yes, I think. Suraksha, try to before I proceed, you can try to maybe rectify your network issues because it will be very difficult. We will not waste time in this. Try to get it connected with some other connection. Huh? Yes. So this child was investigated yes. So as we really pointed out, this is not a good situation as from appearance. It has some dullness is there. Blood pressure has been maintained and some circulation, some issues are there. So bit a compromised kind of child, and this child was investigated in ER, and this is the basic investigation at ER. That means not only ER. This is somehow what we could able to get. This child had. Can you interpret this investigation, Suraksha, if you are online? So I will proceed. This child has hypoglycemia. CBC was 9.8, 3,800 count. Platelets were borderline 1,44,000. Sodium was 127, potassium 3.1. His pH was 7.46, PCO2 is 27. So will not waste time in this, and because this is a chronic respiratory alkalosis. BUL urea was 44, create 1.2. Child was urinary ketones were positive. Serum acetone was there. Mild LFT derangement was also there, and abdominal USG was poor window, gaseous distension, suggestive of partial left pelvic junction obstruction, and few mesenteric nodes are there. If your may I ask if your Suraksha and PGs, what is now interpretation on you these results? Okay, Tarun, you
So
can.
meantime,
we can do a two-way discussion over here.
Yes,
Yeah,
Bhavesh.
Bhavesh sir, you want to add?
so I, by the time they come on online, as you said absolutely correctly, that PAT triangle appears to be the child does not require any, it was not a life-threatening condition at that moment, according to PAT triangle. But of course, the ABCD, the primary, like what we explained, appears to be this child was not in a respiratory failure, either distress, and also not appear to be in any kind of shock. But yeah, so that was like a interpretation on what we should go about. And as Dr. Patki then investigated this child on an ER.
So, what would you comment on the blood pressure, sir?
Yeah, the blood pressure
was
I would
138/84, if I'm not wrong.
Yes, sir. Yes, sir. For a
And
7-year-old child, it is definitely on the higher side, sir.
Yeah, but then go it was 95th. If it is not above the 95th centile, probably I don't think that is also very significant as a hypertension at this moment. Until the rate is consistently above 95th centile.
Okay, so we should keep
Can I add
monitoring
few
on the BP.
pointers?
Yes, sir.
No, I was worried about the blood pressure, and also the respiratory rate was just 20. 7-year-old. He had received midazolam, and his irritability, like why should a child be irritable? The other thing is like things which were not fitting. If he was dehydrated, his heart rate should not be in 70s. It should be
Even
much higher.
70s. Yeah, 70 is less for a 7-year-old as it is.
And who is dehydrated? So there are some pointers like which tell that something is going wrong.
Something
like
else is
maybe
going on.
just missing the system. So he's encephalopathic for sure. Irritable,
Correct.
encephalopathic.
So
And
I would put a
maybe
physiological
like
thing as a acute, acute encephalopathy with probably what the PG said, maybe that could be an element of dyselectrolytemia. But we have to investigate further and keep a close watch on his mental status.
Okay, Tarun, I will ask you now. Before I was about to ask these questions to PGs, but I think they report them correctly.
No issue.
At this kind of juncture, how will you approach this child as a chronic respiratory alkalosis? AKI is there, ketones are positive, hyponatremia.
I would first look out at a few things which are is there anything life-threatening in this investigation as it is? So I think so the sugars are slightly on the lower side. So I would maintain a sugar slightly on the higher. So I would give a dextrose, not a full blown dextrose.
These are the problems. I will
correct.
So, and you can tell Sachin sir and you. So how any child in this kind of situation, what will be the priority to manage? Which investigation should be given the priority to be at first?
Hypoglycemia would be the first one to take care of. Then second would be hypokalemia.
Yes.
And then I would think so I would go for sodium, because since the child is irritable and having symptoms, so it will be symptomatic hyponatremia. So I think so these three things would be the ones which could cause a life-threatening problem. Since it is chronic respiratory alkalosis, it is a chronic condition, so we need not take care of that right now. Plus, we don't know the cause for it. It's just a symptom. Second thing, AKI, I am not sure, because 1.2 creat causing altered sensorium leading to azotemia, uremia, very unlikely. So that seems a little far-fetched. So AKI, I would just keep a watch on his urine output and is the creatinine worsening. That is what I would look at.
Okay. So this child we have started with 10% dextrose, as you said. Then we have done to just correct the hyponatremia to a level of slightly in acute stage. We are given 3% NS 5 cc. We are given 2 things and just try to see the things are improving. And then we put this child on maintenance IV fluid. Sachin sir, any take on this about this kind of situations where we are dealing with
what Tarun had said.
Yes,
I agree with what Tarun had said. So AKI again, he was vomiting and only the creatinine is increased. The BON is not increased significantly. It's still within the normal range. So
Okay.
if he was dehydrated, that could explain like the acute kidney injury. Again, it would fall in stage KD go. By definition, it would be just stage 1.
Okay.
We don't know the baseline.
One
But I agree
question,
with
sir.
what
How we deal with hypoglycemia with hypokalemia? This is a very tricky situation, because when we give dextrose plus potassium, so this is again going to create like insulin kind of. So what did you take? This is okay. This was potassium was 3.2, but it would have been a more severe kind of hypoglycemia and hypokalemia. What could be the way of managing this, sir?
Okay, that's a very tricky thing. If it's a life-threatening hypokalemia or a severe, like if it is less than 2.5, we would give a high K bolus, slow high K bolus, 1 milliequivalents per kg over like 4 hours or so, and simultaneously.
Dr. Bhavesh, can you just check your PGs can come join?
Yeah, I am checked. I think they will join within 2 minutes. Yeah.
So at this stage, Tarun sir, how we should proceed further? So we are trying to correct at the
acute,
whatever and in the year, whatever things are there, we try to correct.
Correct. So, and we have to keep a close watch on the mentation. If the mentation is not improving, then we need some form of neuroimaging, because I think so there is something in the CNS which is causing problems. The headache is not explained, the irritability is not explained. Now the planters are also upgoing and the brisk reflexes. So there is something else, something fishy in the CNS. So I would go for a CT brain if it's the patient is sick. Once we have given the sugars and recheck the if the hypoglycemia is corrected and the child is vital survival is stable, I think so we should go for a neuroimaging. That would be my next investigation of choice.
Okay. So as you said, we have decided to go for neuroimaging. Sachin sir, in this kind of situation, what were the pointers in the history and general examination which lead us to think about neuroimaging in this case?
See, the history is basically the complaint was vomiting. The major complaint was headache and vomiting. And we should have asked more about the headache, like whether it's early morning headache and whether the headache is relieved by vomiting. There was no fever. So less likely of an infective pathology. But neurologically, like what worried me was his headache, then vomiting and irritability, which is like really out of context. And none of these things would be explained by a GI pathology, at least in this the history that you gave. And the irritability was so much that he needed midazolam. And then on examination, he had also hypertension and relatively low heart rate, which made me think that there could be a intracranial pathology here.
Yes. So we stabilized this child and taking care of airway with assisted devices. We went for MRI in this case, and MRI come quite surprise for us. Just I will show. This is a T1 axial image, which then we'll go for flare images, and then we go for a T2 sagittal. If PGs are there, can they interpret this MRI? PGs are there online? Okay, Tarun sir, you can start. I think
I think so. In the first slide, I mean T1, we can just see a hydrocephalus. It looks like a obstructive hydrocephalus, and if you see the sagittal images, there is some pathology in the posterior fossa causing obstruction, and I think so it is a diffuse pathology involving both sides. I think so. It looks like a SOL only.
PGs are there, Tarun. One second.
Yeah. Yes, sir.
PGs are there. I think they will. Yeah. Just can you, Suraksha, just
unmute.
Unmute and talk, please. Unmute yourself. Can you hear us? Just unmute yourself.
Suraksha, unmute yourself.
Ma'am, try now. Ma'am, try now.
Yes. Yes. Speak.
Yes.
So what do you think? What is there?
Sometimes that flare axial in that view, we can see some posterior fossa, some pathologies, sir.
Yes,
So
yes.
as the child has vomiting also and headache, so can be some space occupying lesions, sir. There.
Yes, correct.
Very good.
Yes, very good, very good. Sachin sir, your comment? Just before.
No, this is where this was expected from the histories, I would suggest.
Yes.
Like there is obstructive hydrocephalus with a space occupying lesion.
Yes.
So
yes.
unless I would again go more in favor of a tumor rather than an infective pathology.
Yes.
Correct.
So we did this, and what we got this is a almost 3 by 3 by 3 abnormal altered signal intensity, and a lesion was hypodense on T1. You cannot able to make it here, but if you go here, then what we get, this is a midline posterior fossa medulloblastoma. This was a quite surprising for the family as well as for us. But though we have a very strong suspicion at admission, as Tarun sir and Sachin sir has already pointed out this. So just a clue, or just I can add one point here. Whenever child comes with vomiting, abdominal pain and headache, please don't take these symptoms very casually. There were a lot of pointers from the history. There were a lot of pointers in the general examination at ER also. And this we never miss this kind of thing. So neuroimaging, always I prefer to go for a MRI if facility is there nearby, because lot of delineation is there, and because so this was and this was the fourth ventricle obstruction, and the mass was coming below, and this was a case of medulloblastoma. So this case we diagnosed, and almost we taken all the things, and so on second day we did a midline suboccipital craniotomy, and almost near total excision of tumor was done under G on second day. Shunt was put, as neurosurgeon said, we were put on DEXA, was put on IMSAT, analgesic and all that. The pain and all these things improved on day 2. Post 3, the child was accepting orally well, vital stable, no vomiting and headache. And here serum sodium is 131. So just a quick comment from Tarun. What may be the reason for his hyponatremia, and what may be the reason for his hypokalemia and alkalosis? These are just before I proceed. Just one comment.
So I think so. So vomiting is, that is causing because of the raised intracranial pressure.
Yes.
That can lead to loss of electrolytes. So that can lead to hyponatremia and hypokalemia. So that is one common cause. Second thing, the SOL per se can lead to some amount of deranged hormonal disturbances, such as either SIDH can be there because of the tumor per se, or it can be a central cerebral salt wasting. But cerebral salt wasting will be a polyuric child and the sodium levels is very low. So that seems to be less likely. But I think so SIDH could be another cause if the child is euvolemic or a hypervolemic.
Correct. So this is again one important message from our experts, that whenever you get child with hyponatremia, try to find out the etiology from urinary osmolality, and all that typical protocol is there. And when the euvolemic, as he said, SIDH, where urinary sodium is more, and when you are lot of fluid is wasting, high urine output, dehydration, pointers to a cerebral salt. So what with the correction of removal of the tumor, things went. So here we all were happy on day 3, things we have tackled, and we were going for next things. But day 5 has come up with some problem. Child had started fever, 2 spikes in a day, no chills, GC stable, no headache, vomiting. So at this stage, PGs, how will you investigate, and on what background how will you investigate? Suraksha.
Say the child is developing fever with headache and vomiting, so we can.
There is no vomiting. There is no headache, vomiting.
No
Only
headache.
Hospital acquired infection we can suspect.
Okay, so how will you investigate now? Correct. You are going towards a proper way, because child was intubated, child has been catheterized, child has been sutures are there, surgical site is there. So how will you investigate these kind of children after 5th post-op day? Any child getting any type of surgery, how will you investigate?
So we can do
CBC,
all routine investigations like CBC and CRP,
and we can even plan CSF in this
cytology. We can plan.
Okay, if there is, before going to CSF cytology, anything you can do, you can. So this is the things what we can always try to see the catheter. So try to rule out QATI. Check if it is child is intubated. Try to take aspirations from trachea, send it to the culture and See, if central line is there, try to take two cultures, one from central line, other for peripheral line. And this was the investigations which showed 10.2, 10,000, 16,000 with 86% polys. Procal was 1. Catheter 3 to 4 cells, paracardiac streaky opacities were there. Central line was removed and all samples were sent. So any take Sachin sir and Tarun sir. Sachin sir, I will come to you first on in this kind of cases.
Any again, we talked about the common things: hospital-acquired infections, CLABSI, COTI, and I guess the child was extubated, isn't it? So VAP
Yes.
is
Yes.
yeah. So VAP, but other things, since he has a shunt in situ, shunt infection should be considered, like in someone who has fever, like that would be high on the list.
Yes.
So again, the other thing is, yeah, we can do you can take a tap from the reservoir. We can collect CSF.
Yes, because of occipital lesion, sir, there was no reservoir because this was very limited space and subcorti occipital head terminus there. So we did CSF. CSF was hazy, 110 cells, sugar 45. That time blood sugar was 116. 300 cells, 80% polys, but numerous RBCs were there. So is it just PGs? Is it a meningitis?
Yes, sir.
Because in the view of lot of RBCs, sugar normal, high protein, will you label this as a meningitis?
Ideally, we should do correction with RBC's number. We can see the correction.
So yeah, here you cannot measure the number. Yeah, in numbers. And this child was operated 5 days back, so it is likely that there will be a RBC in this kind of things. So will you label it as meningitis? If it is yes, what is the type? If you are labeling this as a meningitis, what antibiotics you will put and any other test you want to do at this stage? Yes, quick comment.
Yes, sir. This is meningitis. Type is bacterial. Since neutrophils are increased.
Yes.
Polymorphonuclear cells are increased, sir, 80.
Okay, yes. Then what antibiotics you will put on this child?
As there are shunt infections, so there can be most commonly staph epidermidis infection in this child. So we would like to start with vanco.
So since it is post, so we should try to cover more spectrum. So we should start with meropenem.
Okay. Tarun, just what you quick comment from this? They are thinking of meningitis, but in this kind of situation, it is very tricky to put because anyway we are going to send CSF for cytology. Just quick comment on post of CSF we do after 3rd or 4th day.
So the RBCs are expected in a child with post-op cranial surgery. So I think so RBCs, but since the child is symptomatic with raised proteins and low sugars, I think so we should take it. Proteins are very high, sir. 110 is too high proteins to neglect it. I think so we should take it as a symptomatic meningitis and start with antibiotics. I would rather not cover. Send a culture before changing the antibiotic.
Yes, yes. So this way we are sent for blood culture also. We are sent for CSF culture also. One pointer in this kind of cases, high protein can be there for a long time because of osteoid hypertension.
Because of the tumor.
Yes, this tumor can be there. So this, as we have started on monosafe for vancomycin, day 8, fever started subsiding. No growth.
We can also, sorry to interrupt. If you want a rapid, you can also do a CSF biofire molecular test. Can be.
Yes, sir.
It would give you a diagnosis in 24 hours.
Yes, yes. So on day 8, after 3 weeks, child was better. CRP has dropped, platelet improved, hemoglobin was 9.2. Day 14, CSF culture was no growth, GC fair. On Procal this 0.6. Sorry, it is put at 6, but it's 0.6. CRP normal. And we thought it do it in 21 post-op. That means almost 14 days of receiving monosef and vancomycin. The patient requested discharge. They said, now we'll take to our home and we'll continue antibiotics there because we said it is though we could not able to prove on CSF culture because it is we have diagnosed, so we have to give for a long time. So we said we have taken consent for them and they said we'll take it from local hospital and we discharge this child. With red flags, if such and such thing happens, so come back. So this was the story. The story was okay here till here. But on day 1, now this is what we are talking about now. Child has come back. Now child has come back by parents with CSF leak at operated site. This is something new. Child has again had fever, chills, and headache. They said reportedly they have received antibiotics, but we were not sure. Here, systemic examination was within normal limit. Vitals were stable. Here, CRP is 101. HB was 11.5. And here, see the platelets have gone to 5,08,000. Here, we are suspecting about meningitis here. We did CSF tap. But now, this CSF tap is dry. So, how to proceed? Yes, PGs.
So again, this is looking like meningitis only. So we can go and we can do a CT head of this child as there is.
Okay. In this kind of situation, anything else can be possible?
Shunt misplaced.
So shunt misplacement can be there.
Okay. Anything else? So how will you proceed now? What investigation you will order at this stage?
What's up?
What investigation you will order at this stage?
CT brain can be advised.
Okay, so just let's see how things happen. So we added meropenem because he has gone to some another hospital, and he has and we were not knowing, we are not sure about. So vancomycin was restarted here in view of some other, because anyway child was 3 weeks here, 2 weeks they have been some local hospitals. We were not knowing the status. And now day 4 again high grade. Here the problem has started deteriorating. Here he has irrelevant talk plus trembling, intermittent delirious look is there, 100 heart rate 106, SpO2 92, BP here is 134/82. So any clue from this day 1 to day 4 now? Yes, Suraksha, anything you want to get any information?
So they can be engaged ICT leading to.
Oh, okay. So what you want? So you want still neuroimaging, or you want to take CSF from this child?
CSF we can do, sir.
Yes, unfortunately CSF was not there because there was no leak from the operated site, and that was a very difficult situation in this kind of cases. So we did repeat MRI, and see this was a pre-op obstructive hydrocephalus, and see this. So now first from PGs, and then we'll go to the expert. Can you see anything difference in these two cities? First PGs.
So the hydrocephalus has increased in the.
No, it is almost same. You can see shunt now. Shunt is there in situ. That 2 clues I will give. Anything else is happening? As you said, we have ordered investigation. It is come to you now. Okay, we'll go to the experts first. Tarun first, and then Sachin sir.
Sir, it could be cerebral edema, sulcus and gyre. Differentiation is.
It is there. It is there. Differentiation is there. Something what you can see here. Anything you can able to make it.
There is a contrast enhancement, Vinayak, here.
Yes.
And yeah, so obviously there is some infection happening inside, like
yes.
Anything else, sir? Multiple small opaque, radio opaque opacities are seen all over the cortex in the frontal and peripheral.
Looks like communicating.
Yes. Now, yes, Tarun. Yes.
So this looks the lower scans, there could be a communication is there. I think so.
Yes. So now what has happened? This is a obstructive hydrocephalus is turned out to be a non-obstructive or communicating hydrocephalus. Shunt is working well. Now my question is first to the PGs and then to the expert in why this thing is happening. Yes, meningeal enhancement is there, as Dr. Bhavesh has already pointed out, which is looking like opacities here. Shunt in situ are draining well because this CSF leak is there. Now, why these things from pre-obstructive hydrocephalus after surgical removal has gone into the communicating hydrocephalus? Yes, expert. Yeah, PGs.
Increase production.
Yeah, this is a third ventricle.
Fourth is also there, sir. Fourth is also dilated here.
Fourth is also dilated, and the lateral ventricles are also dilated.
All are
dilated. So here we were also, we took again neurosurgeon was involved and neurologist were also involved. And what before anything, any remark before I proceed, sir? Sachin,
Sir, is there any remnant of the tumor can be seen?
Yeah.
No, it is not there. You can see here, no? It is not visible.
No, but Vinayak, was the shunt working properly?
Yes,
Shunt block.
Shunt was working. What explanation? What we got it them that some seedling from the tumor, it can go and obstruct the caries and those final ducts where the CSF get absorbed, and that can lead to this kind of a obstructed hydrocephalus. So this is actually, from neurosurgical point of view, this is a worsening sign. That means obstructed hydrocephalus turning out to be a communicating hydrocephalus is not a good sign. So this we investigated this child, and somehow on same day we could able to get here CRP is 184, CSF again hazy, 5968 cells, glucose only 24, high sugar. Here now neutrophils are 64, CSF blood culture is sent. At this stage now I want to ask PG, is this anything else you want to do in this case? Now you know we are going towards a more complicated thing, and we have done as you expected. We have done a CSF and we have shown the almost same thing is there. Nothing much has changed except for very high CRP.
ZN stain and gram staining we can.
Okay, that will show. That will show what? That will show only infection. No? Anything else you want to get at this stage? So we have just this was because we thought whether it is shunt infection or something which is resistant.
Vinayak, with this picture where he is worsening, and the shunt infection was there in the when the CSF was infected beforehand also, now it is worsening. So obviously the brain parenchyma also, like whether there is an abscess formation, focal cerebritis that is setting in, and we have a shunt which is a foreign body, like maybe we should think about, like the neurosurgeon needs to take a call whether the shunt needs to be removed at this stage, whether we need to put an EVD, just to keep on just tapping as needed.
So these two
those
things
are the options at this stage.
Exactly. At this point of time, we have discussed these two things. In spite of being shunt in situ, child is having meningitis, whether to revise the shunt here or not. So the two dictums are there in that whenever there is active infection, I mean this kind of high proteins, they usually don't touch the things when they give good trial of antibiotics. There, from point of view, we said ki the child has either whatever antibiotics you are giving is the organism is resistant, or the child is that means some other thing is happening, and this thing is any other specific investigation which we want to do, and this we did. So this we did as a separate staining is there, what we called as CSF histopath, and this has something come. So smear prepared, and this is what we called as this is all abnormal cells were there, and whatever we were feeling this is a meningitis is actually a seedling of medulloblastoma. So this was something very difficult. Yes, component
that can cause fever also.
Yes, fever also is there. Component of infection is also there, but so much rise in CRP and all that, what they contributed, that can be a central kind of fever with seedlings of medulloblastoma. These are the possibilities what they thought, and really this is the slide what we get it from here. But here now, see, we have started additional thing what we had done is we added colistin to give just benefit of resistant MDR hospital acquired infection. Day fever 7, fever subsided, but the GCS here started deteriorating, E2, V3, M4. Here now, first time in during cold, the child started desaturating. Now here child started with tachycardia and tachypnea. So we did this X-ray, we'll come to it later. His heart rate was 170, saturation was SpO2 188 on room air. Child is tachypnic, and now 96/68. So here now I will because CRP is reduced now because of your antibiotics, something had worked. We to feel like that. Now question to PGs is, how will you interpret this investigation with the background of this, and how will you interpret this X-ray? Now infection is settling, so we cannot call it as a pneumonia. Yes, PGs. Can you tell the physiological status at this stage now of this child?
General conditions poor.
So what is happening to physiological status? PAT triangle again.
So there is tachycardia, so 170 per minute, and saturation is also falling, and the RR is also increasing.
So how will you call this? This is a shock, not shock. This is what will you call it? Hypox, respiratory distress, failure. How will you label?
Distress.
Okay, respiratory distress with which type of shock you want to see here?
This is a hypovolemic shock. Lactate is 2.23, slightly raised.
Why you want to call it as a hypovolemic shock?
Respiratory failure.
Don't mix two things. One is respiratory failure is different, and another is, so definitely child is respiratory failure, yes. And whether it is a which kind of any comment? I think we'll take comment from Tarun and then we'll go to Sachin sir.
I think so. It looks like disordered control of breathing because the GCS is deteriorating. The child is having tachycardia, respiratory failure. So this is respiratory failure with probably with compensated shock, probably because of disordered control of breathing. So I think so. Since the GCS is deteriorating, so I think that should be the physiological.
Okay, Sachin sir, this X-ray, is it contributing to the, as Tarun said, ki CNS wise his hypoxemia is there? But do you think, Tarun, both this is question both Sachin sir and Tarun sir?
No, sir. X-ray doesn't
contribute to
and
tachypnea is related to CNS.
This looks like bilateral all four quadrant haziness. It could be either ARDS, but I would like to check whether the cardiac status of this child. So it looks like pulmonary edema upfront, but is it cardiogenic or non-cardiogenic? That is the question.
Yes.
But then why should it lead to deterioration of CNS? Is it because of only hypoxia causing CNS deterioration? That is then a reverse way we have to think.
Yes, Sachin sir, from your side.
I agree with Tarun ki there are new onset lesions. So I would think about like a ARDS or a cardiogenic pulmonary edema here, and ARDS I would keep higher up on the list basically.
So whether you will contribute these shadows, because PGs must be also wondering, these shadows to the infection, what it was there, or will not contribute this thing?
Infection will lead to, sir, infection will lead to a particular area of lung involved. It will not lead to all any entire lung on both sides.
Yes.
Very unlikely.
Okay. Okay. So shall we proceed? So at this point of time, how will you proceed? First we'll go to PGs and then we'll come to experts. Yes. So what is this? Now how will you proceed? Which investigation you will order at this stage? Child is hypoxemic, his GCS is poor, he's in shock. How will you proceed?
We can go for 2D cause. Sepsis can cause cardiac failure.
Sepsis has see from 106 na. So CRP has come to 51. There is no fever at this stage.
Still, as the lungs are having bilateral haziness, we can go for 2D echo and see the cardiac.
Okay. Okay, Tarun, anything else you want to do at this stage?
First, I'd like to intubate this. I mean, first take care of the airway and the hypoxia. Otherwise, there will be no child left for echo. So I think
agree.
First, we'll have to intubate the child, put him on pressure. We can see on a bag and tube how much pressure is required, and we can use the optimum PEEP approach to reach and open the lung and maintain oxygenation. Meanwhile, we have to be very careful while intubating this child because this child is operated CNS tumor, so you have to have a cervical spine stabilization. You should not use proper drugs, pre-medications prior to intubating. So I think so. It should be a task, and I would intubate on HFNC. I will continue the HFNC and intubate on the patient on HFNC.
I think, sir, anything you want to add in this comment? Because intubating this child is a very difficult, as we are expecting. Already compromised, raised ICP is there, hypoxemia is there. So you name the physiological status of physiologically difficult airway, everything is here in this child. So
I agree, but it is going to be challenging. So here in this particular child, before intubating, we should have IV lines, give a fluid bolus, keep adrenaline ready. And we would use drugs like atropine and ketamine like prior to intubation.
Lignocaine.
Don't
so
don't use
now we
like
have intubated. Yes, we have
fentanyl is
intubated
okay,
this child.
but no, definitely no barbiturates, no midazolam.
Exactly.
For intubating this child.
So now, how will you any further investigation? As PGs are also pointing towards. So we did a point of care ultrasound here. So this is a point of care ultrasound lung. PGs, can you interpret this? This is on left side. Meaning.
Sir, B lines are visible. So
okay, we'll go see all things and then you can comment. So this is now. Yes.
And there is MR. There is.
And last thing I will show you.
Globular heart.
Dilated.
So first, Tarun, just comment on lung. Then Sachin sir will comment on.
Fluid is B lines as seen as rightly commented. I think so. There's fluid in the lungs.
Yes.
And heart chambers are quite dilated. So left ventricle is completely dilated. Even the left atrium seems to be dilated. There seems to be severe MR also.
Yes.
So and the septum seems to be deviated towards the right side.
Right. Yes.
So I think it's fluid overload or it is cardiomyopathy. So I think it looks more like a cardiomyopathy, which is dilated cardiomyopathy, which is causing pulmonary edema.
Yes, Sachin sir.
The ejection fraction, I think the contractility is also poor.
Yes.
There is a myocardial dysfunction.
Yes. LVEF 30% is moderate MR, moderate TR. Coronaries are normal. LALB dilated.
So this could be secondary to sepsis also.
Okay.
Or the infective process. Like I would be more inclined to think that it is secondary to whatever infection.
So before that, anything in acute stage, this kind of situation, whenever you get this kind of child, in any other circumstances, what will be the line of investigations?
Line of you have already done.
Yes. So I'm asking PGs. These are some investigations, sir. Just PGs.
No, D-dimer, that's fine.
So this is the investigations what we get after deterioration. I told coronaries are normal. This was done by me, not by a cardiologist, because coronary size I could able to make only 2.1. So IgG is positive here, RAT negatives, ferritin 184, CPK-MB 26, and this is a high D-dimer. Suraksha, what is your interpretation at this stage?
As the D-dimer has markedly increased and ferritin is also raised, this is an inflammatory content. Inflammation is definitely going on.
Yes.
COVID IgG is not that specific for COVID. IgG
MIS is not for MIS and that much, but all inflammatory markers are raised.
So how will you manage at this stage? Anything? These are the things what we added. Something I have not added, only just said I added.
We can give IVIG to this child.
Yes?
Steroids.
IVIG. Okay, steroids. Tarun, at this stage, will you use steroid?
No, sir, I don't think so. I mean, I'm not really sure about it, whether it's MIC. IgG positive the second. I mean, I don't. Everybody will be positive for IgG.
Okay, but at this stage now, patient is in shock.
Yeah, first I would give a good inotropic support, like dobutamine, milrinone would be a good option, and stabilize the heart rate. Because more than 170, 180 heart rate with poor perfusion. I think so. First, stabilize the child, get his cardiac output up, and then probably think about the cause. That would be my approach.
Okay. Sachin sir, steroid, IV gamma.
No, I agree with Tarun. I wouldn't jump into giving steroids or for that matter IVIG also.
Okay.
Because I would still attribute everything to the primary pathology, primary this thing and the
Sir, for
sepsis.
treating this high D-dimer, will you give heparin at this stage or no?
Will I give? Sorry?
Heparin at this stage or aspirin at this stage?
No, we would not give heparin because he had a neurosurgery. There is always a possibility of him bleeding.
Yes,
so
correct.
I would not do that. Neither I would give aspirin for this particular patient. I would first treat his cardiac function rather than giving him IVIG.
Okay.
And try and normalize and see how things evolve over the next 24-48 hours.
Agree. So let's see, go further. So on day 10, that is GC improved. This is heart rate has dropped now. And what you can see, this is the third day. Within 3 days, what you get this kind of X-ray, consciousness improved, no fever spikes. He was put back on HFNC, chest X-ray input. So what, retrospectively, what it was, Suraksha, if this kind of picture you get and gets clear within 48 hours, what will you label retrospectively?
The cardiac condition only causing the...
So it was a pulmonary edema, as Tarun sir has really pointed out. It is a very difficult for say because cardiac function was deranged at this stage, so we have to contribute this to the cardiac status. But if cardiac status would have been normal, we would have labeled this as a neurogenic pulmonary edema. When you get some significant raised ICP and all that, but this possibility remains on lower side because she has already cardiac compromise is there. So just we'll move further, day 10. So now see, this is consciousness is improved, HFNC patient is stable. And this is CSF has come like this, culture has come like this. So any comment on this? Yes. So this is a MRSA basically, which is sensitive to vanco, teicoplanin, trimethoprim and chloramphenicol, everything. So, but unfortunately, this was second CSF we did. First CSF was normal. Blood culture, no growth. We have done 2-3 cultures. Nothing we could able to growth. We could able to get only his from CSF culture. Now going further. So adrenaline and milrinone were tapered, meropenem stopped. As per culture sensitivity thing, we are Genta was added to the vancomycin 10.1 ABGs. Now just see how this ABGs 7.76, 18.8, 151 and 26.4 lactate is. So comment from PGs, why this thing is happening? What is this? Child is absolutely okay now. What is this thing is happening?
ABG suggestive of respiratory alkalosis.
Yes. Okay. Surprisingly, we did repeat his echo, and see the echo here. So within ejection fraction has improved, but see here, what we can see here is a vegetation at anterior mitral wall leaflet.
My God.
This is a still patch we have taken. Ejection fraction is almost better. Here now we could able to see, and that also we taken from a pediatric cardiologist, and he says that this is a healed thing, healed vegetation on anterior mitral leaflet. So Tarun sir and Sachin sir, comment on that. You are expert on this.
Never seen healed vegetations. Only seen vegetation. Never seen healed. I don't know how to differentiate between a healed vegetation and an unhealed.
Yes, there seems to be some kind of because if this would have been a real acute infective endocarditis, it would have been a late stage to a flourishing like a fungal ball-like thing, or which would have expanded and all that.
Okay.
Because of this, maybe antibiotics and these things, and so it is a very now two quick answers from Tarun and Sachin sir. How we will contribute this cardiac deterioration? This whether it was an acute infective endocarditis or something related to the acute myocarditis kind of thing.
Looks like that's acute infective carditis rather than myocarditis. Because it was what we have seen myocarditis, especially during the COVID era, there was like very high ferritins, very high CPKMBs. These CPKMBs and ferritin was not very high, first of all. So okay, they were raised, but not as to what we used to see in myocarditis. So this is more like a acute infective carditis leading to cardiac dysfunction, and which we corrected by ventilation and inotropes, and probably and antibiotics worked. So then the infection has gone down and the cardiac function improved. That's what it looks like.
Okay, Sachin sir. Quick comment from you.
See, it is very, very semantic. because carditis, myocarditis, endocarditis, they all could exist together. And since the response was very dramatic, like the child improved within 48 hours of your like symptomatic treatment. So I feel that it is something very acute, like it could be more of an infective thing which has caused this. And your antibiotic, the right use of antibiotics and fluid, like getting rid of the fluid helped him. So I personally would think it was more of a myocarditis and myocardial dysfunction element there. But again, that is semantic. How does it matter?
Yes. So how do you explain the alkalosis, sir? Respiratory alkalosis?
See, does he have a CRS? Is he hyperventilating because of CNS reasons?
So no, actually, clinically he was not hyperventilating. But what we can get is a very peculiar of this child. Throughout his course,
stay,
he was having chronic respiratory alkalosis, and we purposefully are not intervened for this thing because he was hemodynamically stable and other things were absolutely okay.
Agreed,
yes.
But this has got aggravated this time because we use diuretics. Because now he's hyperventilating himself to such an extent that the pH is abnormally high.
Same point I was about to discuss. Because we are using diuretics, now here is a metabolic component.
Metabolic alkalosis.
So what we can call it as a contraction alkalosis, exactly hit by Sachin sir. So whenever you use, this is a quick tip for all of you. Whenever you use diuretics, be sure that over a period of time you lead to a contraction alkalosis, that is a metabolic as well as respiratory. Then this day 15 stable, HFNC sensorium better, count better, CRP dropped, proteins were still high. We did repeat CSF also for this child, but again proteins were high and all the cells now were they are said to be a malignant cells. So there is no question of meningitis. Now day 18 again problem has appeared here. We have shifted this child on oral diet, Vanco, and shifted the moment we shifted this child to ward, he had again episode of hyperactivity, delirium. Again his sensorium level was problem. He was confused, he was obey, and he is seeing a death, impending death kind of thing. He was telling to parents that something is going to happen to me. So now question to PGs is why this is happening now. We have treated infection, we have treated a lot of things. Now this is happening. The child once we shift to the ward. Any comment from you? And then we'll go to experts. Is there? Yes, please.
Sir, while surgery, there might be some trauma to meds and trauma to occipital lobe that can cause visual hallucinations.
Okay, any other question?
Can be there, sir, leading to all this.
Because now we have corrected treat infection, we have corrected alkalosis, we have corrected the electrolytes. So still this is something new that's happening to this child. Okay, Tarun, as time is
this happened after shifting to the ward, so this could be PICU psychosis, what we call, because this happens only when you shift the patient out of the PICU, and that time the patient has this feeling of impending doom. So he feels that he's safe in the PICU, but when he goes to the ward, he feels that he might die over there. So this is something which is quite rare but known.
Sachin sir.
See, this patient, like we need to give attention to sedation, analgesia, delirium in the ICU. It highlights the fact since he was sick in the ICU for a long time, he must have received multiple medications. So drug withdrawal and delirium is what, since you have already mentioned that, we would use standardized scales for monitoring his delirium, the Cornwell or one of the scales.
Yes, we have used scales. We have tapered his sedation very properly. In spite of this, child has developed this. So what you will label this as?
So again, as Tarun said, the PICU psychosis, it's a known phenomenon. But we will have to treat that, I told you.
Yes,
we have to treat it. It's not something.
So this is what we call as an intensive care unit psychosis, or what we call as a post-ICU syndrome, also labeled as ICU syndrome, and it requires a multidisciplinary approach. Psychiatrist, psychologist, nutritionist, neurophysician. We put this child on risperidone. This is a atypical antipsychotic in a graded manner. So it started with 1 milligram OD. We started slowly. We started increasing, and within next 3-4 days, though his sedation, his aggressiveness has come down and all that, but but over 3-4 days he could able to achieve as a normal thing. And so day 21 of his no delirium, no fever, fully awake, his starting oral acceptance good, and child was not planned. And because meanwhile there's all reports of this cytochemistry and markers have come, and he was responsive. They said some chemo can be tried with the radiotherapy.
So we will need chemo and radio.
Yeah, so this is a triple therapy, what we can call. And this child was this child has been discharged without any deficit at particular. We are just following his radio and chemo results. So just before summing up and I just went to the literature. What can be there in this kind of children? Though we are not sure. So in invasive pyogenic infection and infective endocarditis due to staphylococcus. So this is a case report in very recently from 18 years boy. This is known thing. And this is a series of infective endocarditis and in adults with bacterial meningitis. So both can happen simultaneously. And so we have one staph pyogenes meningitis and endocarditis in a prosthetic wall. So we have this kind of case reports also. And this is a very good article what we got from 2022. This is from Infectious Disease Journal. So what it says is a combined bacterial meningitis and infective endocarditis can be there. And when should we search for the other when either one is diagnosed? This is a very good article. All of you can go through this article. Very important. It displays. So this is the complexity of the case has been, and you can, if you go through it. So one can lead to other can lead to one. Our aim is to give try to hit the etiology as good as possible. And just before concluding, one remark from Sachin sir, Tarun sir, and then I will put final remark, and then I will put mic to Ram Gopal sir. First Tarun, then Sachin, then I will put.
Interesting case, very well managed, I suppose, and with so many complications. One thing I would like to comment is if there is a shunt or some device is there in place, especially central line and a shunt, and so we should think about, I think so that retrospectively, of course, we should think about something causing such severe sepsis and myocarditis. So very interesting case, definitely. But a funny thing was the blood culture never grew despite having vegetations on the mitral valve. So that is little, I mean, sometimes these organisms just flummox you to such an extent that you completely have to revise your protocols. So very well managed, sir. Excellent case.
Sachin sir, your comment from you.
Yeah, nice case and very well managed. My comment is basically to initial assessment. Since it's a PG case, see, we should not jump to a diagnosis. First, before you look at a clinical diagnosis, we should assess the physiologically diagnosis, try and if we can identify the system which is involved, and then come to a diagnosis. That way we are less likely to make mistakes. And also try to think laterally, like just because there is vomiting doesn't mean it is GI, and same thing, like just because there is headache doesn't mean it has to be CNS cause. There could be other causes also. So try and think laterally, have a differential diagnosis before you order investigations. Don't stick only to single diagnosis. That would be my take-home message for the PGs.
Okay. Before coming to comment, Dr. Suraksha and PGs have done an excellent job. They have, at whenever point, they have advised investigations properly under the mentorship. So they have been trained, and this kind of situation can come. Thank you, Dr. Bhavesh, for mentoring them in a good way about PALS thing and giving them approach about ER, how to go about it. Just quick comment from you, then I will put a concluding remark. Bhavesh.
Yeah, so like I absolutely agree to Sachin sir that what happens is most of the PG students, when asked properly, then they might able to answer a PAT and ABCD approach of PALS. But suddenly when case comes with the patient, probably they just lose it. But I think that happens because every PG has to do it every day in every patient. That was a take-home message, because very nicely pointed that there was an indicator that it was a CNS case. Surely. And not only that, but in between also, when the case shifted from again CNS to CVS, actually the indicators were there that now the case is CVS and not the CNS, because that endocarditis is leading to cardiogenic shock. was again, so I think that is what Sachin Shah said, and I will always keep on mentioning for PGs that basics and physiology, explaining the physiology for each symptoms and signs should be the way to go ahead and then investigate the case.
Okay.
Thank you.
So just putting thank you PGs for their active participation, Bhavesh Shah sir for mentoring, Sachin sir and Tarun sir for excellent putting your remarks at particular stage. So this was a really difficult case for us to manage also. So always I always teach my students to keep a wide vision. Don't keep it to the kind of tubular vision. So many things are happening, and intensive care is a quite dynamic process is there. So always try to try to get whatever pointers are there in front of you. Try to analyze this. Don't try to keep your things fixed at one stage. There may be deterioration. Don't just go away from, and don't just lose up when you case deteriorated at a particular moment when child has hypoxemia and shock. All of us, we thought we are going to lose this child, but we did. And now one more important thing is try to take much help from your point of care ultrasound and point of care test which are available with you. So if it is not your domain to touch the neurosurgery and other finer aspects of it, but you have to prepare this case for proper post radiotherapy and chemotherapy in this kind of cases. These are difficult, challenging cases, comes once in a while. Always send cultures, try to remain with the basics, and try to explore all possibilities to save the life of child. I think this is from my side. Thank you again, all my PGs, mentor and experts. And thank you very much, Ram Gopal sir, for giving us this kind of opportunity. And Bhavesh is not there, I think, today.
Yeah.
This concept is basically from Dr. Bhavesh Mithia. Rajesh Kulkarni sir also here. He can put some comment. Yes,
Rajesh is there.
Here.
Rajesh.
And yes, over to you, Ram Gopal sir.
Thank you, Vinayak Patki sir. This was again a hat trick of Googly. This is third time you have done it. As Dr. Sachin Shah has already explained the concept and the approach, I think he has put it in a very nice word. When we planned the series, Dr. Rajesh Kulkarni, Vinayak Patki sir, and myself, and Dr. Bhavesh, the concept of initially we thought of PGs, then we thought we should involve everyone. So then the concept was designed to involve the PG students as well as the practicing pediatrician. So the discussion which is going on, it is useful for both the PG students also and for the practicing pediatricians also. Once we approach towards the diagnosis, then only we can take a proper decision or to involve the specialist or a super specialist. So thank you, Vinayak sir, for guiding us. Next time, I think again you will have one more such case.
Yes. So till then, next Casebook Live, I sign off from my MahaIP team. And thank you very much for joining and giving your inputs. Thank you very much.
MahaIP would
Thank you, everyone.
Dear friends, MahaIP would be releasing their first magazine on 6th at Nashik on Darpan. And you will get as the digital copy of Darpan.
So thank you very much.
Okay, thank you.